My apologies. So welcome to the NANETS monthly virtual programming session and the management of functional neuroendocrine tumors. My name is Jaydira Del Rivero. I'm a current board member of North American Neuroendocrine Tumor Societies, and I'm associate research physician at the Center for Cancer Research at the National Cancer Institute. It is my pleasure to moderate today's educational webinar. Our featured speakers will give a presentation, and then we will engage the audience for a Q&A discussion. The activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education and the American Nurses Credentialing Centers Commission on Accreditation. You will earn an AMA PRA Category 1 credit and nursing credits. A link to obtain credits was provided by email to all registered attendees today and will also be provided post-webinar. NANETS is committed to increasing diversity within our activities and is structured to reflect all aspects of the neuroendocrine community we serve. We strive to cultivate an open, transparent, and supportive culture where all are welcome. We encourage members to contribute and participate fully. For more information, please visit nanets.net. Now, it is my pleasure to introduce our speakers and case presenters for today. First, we have Dr. Guillaume Pegna, who is an assistant professor of medicine at the Oregon Health and Science University, who will be presenting on functional small bowel neuroendocrine tumors. We also have Dr. Mark Anthony Jara. He's an assistant professor at the University of Miami, who will be presenting on functional pancreas neuroendocrine tumors. And last but not least, we have also Dr. Sarimar Agosto Salgado. She's an assistant member of the Department of Head and Neck Endocrine Oncology at the Moffitt Cancer Center, and she will be presented in one of my favorite topics, pheochromocytomas and paragangliomas. Just on housekeeping items, following the presentations, we will have a Q&A session. Please place your questions in the Q&A box for our moderated discussion. With that said, let's get started. Dr. Pegna, the floor is yours.
Thank you so much, Dr. Del Rivero, for the introduction. So to go ahead, get started with the session here, I'll be discussing specifically functional small bowel neuroendocrine tumors. Here are my disclosures, and the learning objectives of this part of today's webinar is to review the presentation and diagnosis of carcinoid syndrome in functional small bowel neuroendocrine tumors, the first-line management of carcinoid syndrome, and then the management of refractory carcinoid and carcinoid-related complications. So jumping right into carcinoid syndrome, and really carcinoid syndrome is the bulk of the talk here, because classically the tie between functional small intestine neuroendocrine tumors and the carcinoid syndrome really defines a large part of this disease here. So carcinoid syndrome is actually a clinical constellation. It's been recognized for more than 100 years, and over almost a similar period of time has had a clinical pathologic correlation in patients with neuroendocrine tumors found pathologically. And it includes a constellation of symptoms, most commonly cutaneous flushing and diarrhea, less commonly bronchospasm, as well as cardiac valvular fibrosis. And with this last one being the least common, but really the most concerning potential complication. It is mediated by the hypersecretion of bioactive substances by neuroendocrine tumors. Note that I'm saying substances and not necessarily serotonin. Serotonin is classically thought to be the connection in carcinoid syndrome, but what we know now is that serotonin is just one of probably dozens of substances that are secreted by neuroendocrine tumor cells that can act through different pathways to cause these clinical constellation of symptoms. Now, the clinical presentation of neuroendocrine tumors, specifically small intestine or neuroendocrine tumors, is seen in the context of these being very quite common neuroendocrine tumors, perhaps not the majority of neuroendocrine tumors, but likely at least the plurality. But out of all small intestine neuroendocrine tumors, only somewhere between 6 and 30% are thought to develop the carcinoid syndrome. Based on clinical experience, that's probably around 20% or so of patients will develop the carcinoid syndrome. And development of the carcinoid syndrome has a lot to do with the anatomy and where these tumors are located in terms of their production. So when we look at the small intestine here, the lymph node drainage to the small intestine and the venous drainage specifically goes through the liver before the venous drainage then going into the systemic circulation via the hepatic vein and the IVC. Now, a lot of these bioactive substances that are secreted by tumors in the small intestine will actually never make it past the liver because they get degraded by monoamine oxidases and never are able to exert the systemic hormonal effects. That said, it's not to say that these functional tumors are without symptoms when they're located only in the small intestine. The synonymous with these and oftentimes functional tumors, and diarrhea can also present prior to the development of metastasis. Now, however, to get really the full systemic hormonal effects of the carcinoid syndrome, what's critical here is being able to bypass this enterohepatic circulation. That's typically done once these tumors metastasize to the liver and they're able to drain directly into the systemic circulation, or the other possibility is in the setting of bulky extrahepatic metastases, where these are released directly into the systemic circulation and bypassing hepatic metabolism. Now, in terms of diagnosing carcinoid syndrome, what's helpful here is we actually have a very good test for it as long as it's done correctly, and that's the 24-hour urinary excretion of 5-HIAA with the sensitivity and specificity exceeding 90%. Now, I will say that both numbers are probably higher in small intestine neuroendocrine tumors. What we know can cause false negative results for this test are typically actually foregut or hindgut neuroendocrine tumors such as rectal or lung carcinoids, which very rarely will cause the carcinoid syndrome, but we know that they sometimes lack the final enzyme in the creation of 5-HIAA, and therefore sometimes you need to have an increased degree of suspicion in those patients with a negative urinary 5-HIAA. Now, also of note, there are many foods, avocados, fruits, nuts that can cause erroneous false positive, false negatives. So these are, this is a list of medications to avoid 48 hours before and then during testing. Now, any patient with a positive urinary excretion of 5-HIAA confirming a diagnosis of carcinoid syndrome needs to have a baseline echocardiogram. I'll talk a little bit more about that. Now, while we have one good test for carcinoid syndrome, we have a lot that are not necessarily quite as good, and not recommended are chromogranin A and serum serotonin. These are just, there's too much intra-patient variability during the time of day affected by medications and foods. And then there's other tests where we just really have insufficient data to support their standard use, with a specific focus on serum 5-HIAA, the NET test, and some others here. When we talk about the management of carcinoid syndrome, there's a lot of overlap here, which is really something that defines carcinoid syndrome, in that we're talking about wanting to manage it both to decrease the morbidity and mortality of carcinoid syndrome, but really the symptoms of carcinoid syndrome can be extraordinarily debilitating. So there's a fair amount of overlap when we're talking about wanting to improve outcomes for patients, but also in wanting to improve symptoms. But there's also treatments that are mainly focused on symptom management as well. Now, this overlap of risk reduction and symptom management is really the bulk of what I want to talk about. And these include multiple interventions, including the somatostatin analogs, octreotide LAR, lanreotide. I do have a note here, long-acting somatostatin alone typically is appropriate for most patients without severe symptoms. Sometimes in the setting of severe symptoms or in the setting of symptoms that recur before the next dose, increased frequency or increased dose of the somatostatin analogs is needed. And not infrequently, I will also use bridging doses of short-acting octreotide in those situations as well. Then a lot of the other interventions involve actually removing metastatic bulk that is producing these substances. So liver debulking surgery, local regional hepatic therapies, TACE, TAE, TARE, all these acronyms that our interventional radiology colleagues like to use. For patients with cardiac involvement, and this is one of the things I want to stress, is prompt referral to cardiac surgery for evaluation of valve repair and valve replacement is really critical. Vitamin deficiencies, classically niacin, but also the fat-soluble vitamins can develop frequently. So referral to nutrition is quite important. And the classic niacin deficiency that develops is the syndrome of pellagra. In terms of monitoring, even if a patient has a normal baseline echocardiogram, anytime I do labs on a patient with carcinoid syndrome, I get a pro-BNP, and a pro-BNP that's positive triggers repeat testing via echocardiogram. Now, it would be outside of the time scope for today to go through each individual treatment and its effects, but I want to emphasize that the treatment of carcinoid syndrome is really multidisciplinary. As an oncologist treating and providing somatostatin analogs, the basis of this has been established really since 1999, the long-acting octreotide dosing, which can result in a 50% or greater reduction in the symptoms of carcinoid, here specifically being the number of stools per day in the evaluated patients. But on top of that, we know from the ProMed and the Clarinet study that these drugs work also to extend the progression-free survival. So it's both this risk reduction and symptom management. Then when we talk about liver debulking and removing metastatic burden of disease, we can also obtain long-term control of carcinoid syndrome. This is some of the early studies looking at what was called then optimal tumor debulking, 90% or greater in patients with carcinoid hepatic metastases. I'd be remiss not to mention some work from my colleague, Dr. Rod Pamier, who showed that 70% is adequate for many patients as well. In terms of the symptomatic management of carcinoid syndrome, these include a wide variety of antidiarrheal therapies, Imodium, Lomotil, tincture of opium, but really it's important to assess for other sources of diarrhea, fat malabsorption, steroiduria from chronic somatostatin analog use. In these patients, consider pancreatic enzyme replacement. In patients with small bowel resection causing bile malabsorption, considering cholestyramine or cholesterol. And then for somatostatin analog refractory carcinoid-related diarrhea greater than 4 bowel movements a day, telotrecet ethyl was approved. And just to mention very quickly the results of the TELESTAR study. So telotrecet ethyl blocks the synthesis of a precursor of serotonin through blocking tryptophan 5-hydroxylase, and was shown to significantly reduce the number of bowel movements per day in patients with otherwise refractory carcinoid diarrhea. Now, just to mention really briefly the management of patients who still have diarrhea in spite of optimal treatment, PRRT with Lutathera works in some patients, probably around 30 to 40% of patients in terms of improving their carcinoid symptoms. Everolimus may have a limited effect based on some of the early RADIANT data, but something to consider. And then I just mentioned low-dose interferon alpha. This is not something I've used. It's a very old drug, and a lot of this data predates the use of long-acting somatostatin analog. Now, 2 complications I just want to mention here. One is carcinoid heart disease, and as I mentioned before, this is really one of the most important sources of morbidity and mortality in patients with carcinoid disease. As you can see here, the mortality is almost double once carcinoid heart disease develops. So these patients really require prompt referral for valve replacement or repair, particularly at experienced centers to improve outcomes for patients. And then lastly, just to mention carcinoid crisis. This is a life-threatening hyperacute form of carcinoid syndrome, typically triggered by tumor manipulation via surgery, anesthesia, rarely treatment of tumors. It used to be really kind of dogma, the use of prophylactic perioperative octreotide, but this is no longer necessarily recommended due to the potential lack of efficacy in preventing carcinoid crisis. There are some trials I'm just mentioning here. I think I'm out of time, but just actively looking at improving symptoms and improving outcomes in patients with carcinoid syndrome. So thank you so much. I will pass the floor back to Dr. Del Rivero.
Thank you, Dr. Pegna. That was very informational, excellent presentations. Now I would like to pass it on to Dr. Jara.
Thank you so much, Dr. Rivero. So the learning objectives of the talk of functional and pancreatic neuroendocrine tumors is identifying, classification, and grading on the neuroendocrine neoplasia and review the diagnosis and the management or neuroendocrine tumors, specifically pancreatic neuroendocrine tumors. So although they are very rare type of tumors, the incidence of these tumors in the last 25 years has continued to rise. And although the cause is not well known, and some possibilities are related to the increase of diagnosis or early diagnosis, better detection technology as we have now, or even the possibility of improved awareness. So the increase of these tumors in the incidence of, or the incidence of neuroendocrine tumors since 1973 to 2012 occurred across all sites, all stages, and all grades, including, as you see on the right, pancreatic neuroendocrine tumors that are also rising. So it is important to see that the grading for neuroendocrine tumors or neuroendocrine neoplasm is essential for risk stratification and optimal selection of therapy. The grade describes how quickly the cancer is likely to grow and spread. And for pancreatic neuroendocrine tumors, an important part of grading is measuring how many cells are in the process of dividing into the new cells. And this is determined by two things: those special ones that are mitotic count, which is the number of cells seen under the microscope that are in the process of splitting, and the Ki-67 index, which is a measure of the portion of the cells that are almost ready to start splitting. Now, in the 2017 revised grading system, and a new subset of well-differentiated neuroendocrine tumors was recognized, and lesions that are morphologically like well-differentiated and often identical to a grade 1 or grade 2 neuroendocrine tumors, but have a high Ki-67 index was added to a grade 3 now. And furthermore, the genomic features of the grade 3 neuroendocrine tumors resemble those of the lower grade neuroendocrine tumors, like multiple endocrine dysplasia type 1, DAX, ATRAX mutations, and differ markedly, I will say, from the genomic alterations in poorly differentiated neuroendocrine carcinomas, usually P53 or RB1 mutations. Also, about 10% of the patients with pancreatic neuroendocrine tumors occur in patients who have a cancer predisposition syndrome. And these syndromes include MEN1 or von Hippel-Lindau or neurofibromatosis type 1. Now, we can classify the pancreatic neuroendocrine tumors in two groups: functional and non-functional pancreatic neuroendocrine tumors. The functional neuroendocrine tumors induce a dramatic clinical symptoms with overproduction of endogenous hormones or vasoactive substances, as we see here, different peptides depending on the location or the organ of secretion, producing different symptoms and syndromes, going from hypoglycemia to physical signs as necrolytic migratory erythema in gluconomas or profound diarrhea in lipomas. We're going to focus a little more on insulinoma on this one. So the diagnosis is based especially on three cornerstones. In histopathology, biomarkers as a number one. We need a biochemical confirmation and radiologic evaluation that includes non-functional and functional imaging. Now, in our toolbox of medicines for the management of pancreatic neuroendocrine tumors, we have multiple options, starting with surgery on somatostatin analogs, or especially for symptom control, localized treatment options, as well as systemic therapy, based on the main objective that is control of symptoms and control of growth of the tumor. And unfortunately, there is no simple rule of sequencing and when treating neuroendocrine tumors. And we don't have such a data yet to guide us and tell us who comes first and what comes next. And that makes the management of neuroendocrine tumors very challenging and to an extent unique for every patient. And this plan has to be built and I will say share the decision process with the participation, of course, of the patient, and a multidisciplinary team has to be addressed in order to decide the treatment. Now, for the treatment and sequencing of these tumors, there are certain factors that has to be taken in account before making a medical decision. One is the tumor factor, that is the grade and differentiation of the tumor, which is the first one to help us guide our decision, as low grade or high grade tumors are approached completely different. And second is the localization. The site of the origin is very important, as some tumors can cause, depending on their location, symptoms as jaundice if you are in a primary pancreatic tumor, or obstruction in a bowel tumor, or maybe bleeding in a rectal tumor, for example. Now, the third part is the tumor functional or not functional? That's because the treatment of these side effects or these symptoms have to be addressed. Sometimes the size itself can produce symptoms. And lastly, the biology of the tumor is very important. Slow growing tumors that is in the mode of cruising are treated differently as an already speeding up tumors. The other important factor is the patient and its comorbidities. For example, in a patient who has uncontrolled diabetes, for example, everolimus can increase blood sugars, and this might not be the best option for this patient. But the same drug in a patient who has hypoglycemia might be the perfect fit. So other example would be patients with bleeding ulcers. And sunitinib is a drug that can produce bleeding, so because of its mechanisms, and of course, this might not be the best option in that patient. So it is very important to think on the treatment option. And if you choose one route to go, know how a route can affect the next step. So all this consideration has to be taken in account when choosing the therapy. And of course, a multidisciplinary approach is very important for that decision. Now, going back to our toolbox of options, somatostatin receptors are present in the surface of most of the cells. And there are 5 types of somatostatin receptors. 80% of this neuroendocrine tumors express somatostatin receptors type 2. So they work by inhibiting acting on adenyl cyclase, lowering cycling AMP, and producing inhibition of the calcium voltage, the outward potassium channels, and leading to hyperpolarization that actually decrease the hormone release. That's the way they function and was the idea on actually the drugs that we use today. So synthetic longer acting analogs, octreotide and liraglutide, were approved for the treatment of pancreatic neuroendocrine tumors. The improvement in progression-free survival that we see in 2 trials in PNET and in CARINET in patients with unresectable, like metastatic small bowel syndromes, established these drugs at the beginning. On the PNET study on the left, we saw a 14.3 months and lengthening of the time of progression comparing to the placebo. And also in CARINET, we saw, although at the time of publication, the median progression-free survival was not really reached yet, there were 18 months and for the placebo group. Now, the hazard ratios for this disease progression or death generally favor lenalidomide over placebo. So somatostatin analogs might be an appropriate first line in most of the well-differentiated neuroendocrine tumors. So when starting with a case, I give you just a short version of it's a 63-year-old male with multiple endometrial neoplasia, has primary hyperparathyroidism, developed a gastrinoma, and later thereafter pancreatectomy of the distal aspect of the pancreas. At age 56, developed an insulinoma. We can confirm that with biopsies. So it was actually histologically proved. And on the right, you can see the radiologic proof of the disease and the extent of the disease. This is also supplemented by the biochemical diagnosis with what we use usually as a confirmatory test for insulinoma, that is a 72-hour fast. We can do a 48 hours now as well. In this case, you can see at the 5-hour mark, sorry, my pointer is not working, but at the 5-hour marks, we see that the patient already has what we want. It's like a glucose levels less than 50 to be able to assess the rest of the hormones. And in this case, we see a rise, as within the darker dots, that is a rise on the insulin levels. That is completely inappropriate physiologically. Now, insulinomas are the most common in functioning pancreatic neuroendocrine tumor. 90% of the insulinomas have reported to be benign, and most of them are intrapancreatic, and 10% of them can have a relationship with multiple endocrine neoplasias. Important aspect about this is for the diagnosis are the symptoms. In common autonomic symptoms like diaphoresis or palpitations, these autonomic symptoms are due to the perception of physiologic changes in the autonomic nervous system in response to hypoglycemia. And the most important may be the neuroglycopenic symptoms because of the effects, results from the brain deprivation of glucose during the hypoglycemia. In this case, can lead to not just confusion, but seizures and coma. So for diagnosis purposes, we usually have the Whipple triad that includes hypoglycemia of less than 15 on blood, neuroglycopenic symptoms, and of course, and prompt relief upon administration of glucose. An important thing to look for the diagnosis is the gold standard, as we saw before in the slide, and usually using a 72-hour fasting. And important is we use glucose, insulin, C-peptide, and proinsulin as a surrogate for the diagnosis. All of these should be increased in these kind of tumors, and there should be an absence of plasma sulfonylurea. So an important drug that we use is deoxycyte. This is usually in benign patients. We can usually also in other circumstances. It helps controlling the blood sugars, and the primary mode of action is through the ATP-sensitive potassium channels. It actually enters through the glucose, as you see on the right, like GLUT2 channels, produce an opening of the potassium channels, hyperpolarizing the cells and closing calcium channels, inhibiting insulin resistance. That helps to control the symptoms, decreasing the insulin secretion, decreasing hypoglycemias. 10% of the patients are not responsive to this drug or really not tolerated. In that case, we can use somatostatin analogs as well. So continuing with the previous case, just better time, I'll go a little faster with the cases. So in this case, the patient was on deoxycyte, but had progression of disease. What would be the next best step? And in this case, the next best step will be using everolimus. The reason for this is two reasons. Like actually the disease is progressing. We want to halt that progression, and at the same time, control the hypoglycemia. So in the RADIANT study, the median progression-free survival was 11 months of everolimus compared to 4.6 months in placebo. But just not showing that it can actually reduce the risk of progression, but at the same time, via the mechanism of action of this medicine, by acting on an mTOR pathway and PA3-AKT pathway, actually, so you can actually have a reduction of the secretion of insulin, producing at the same time decreasing on the symptoms, in this case, and hypoglycemia. Now, we have another drug in our toolbox that is sunitinib. This was also shown to have progression-free survival that is significant and actually produce stable disease. Now, choosing between one and the other is based clinically on the symptoms and the characteristics of the patients. So we have to see the comorbidities to choose which one is the best depending on that situation. Just moving to a little more advanced disease, in this case, in a patient who has a grade 2 well-differentiated tumor that initially was stable and progressed, especially we can see on the right side with a clear progression on the liver, where the tumor initially was undetectable, now is 5.8 centimeters. We see clear progression of disease. So in this case, the tumor is rushing. So in this case, they change our approach, and the most adequate treatment will be use of Captain in this case, starting with systemic therapy. So in that case, with the Neck-Endocrine study, it was evaluated before, and in the median progression-free survival was 14.4 months, comparing to telosomavide 22.2 months, with associated an improvement in progression-free survival in this case. To complete now the toolbox that we have for treatments, we have also lutetium-177. This was studied initially in other type of tumors. In this case, was midgut tumors. Show actually an improvement in progression-free survival and control the tumors in more than 65% of the patients, with a shrinkage of tumor in 19%, and there was a 79% decrease on the risk of progression. So, of course, for just in European society has a, also we don't have a specific way of like following. They actually give you a small follow-up on how you can actually approach these tumors, and a little different to what we have here. And of course, as a conclusion, 10 to 30% of the pancreatic neuroendocrine tumors secrete hormones. And the biochemical assessment is important, as well as the imaging. Surgery will be always the cornerstone of treatment to reduce clinical symptoms if the tumors are adequate for surgery. And of course, advanced treatments are for progressive disease. Thank you.
Thank you so much, Dr. Jara. That was a great presentation. Now, finally, let's hear from Dr. Agosto Salgado.
Thank you for your kind introduction. So to speak about pheochromocytoma and paraganglioma today, these are my disclosures. And the objectives of this part of the webinar is to describe the frequency of pheochromocytoma paraganglioma, the proper diagnostic evaluation, review implications of genetic testing and adequate preoperative management of these patients, and provide a summary of the available therapies for advanced pheochromocytoma paraganglioma. Pheochromocytoma paragangliomas, or PPGL, is a rare orphan disease that has been reported in up to 8% of all adrenal tumors. It has been associated in about 40% to germline mutations, hence the importance of genetic testing. And it can have metastasis in, on average, at least 25% of cases, where 50% of these metastases can be synchronous, occurring at the time of the primary tumor, or 50% developing later on the disease course. It is present in 0.05 to 0.1 of all hypertensive patients, with an incidence in up to 1,600 cases in the USA, and presents on average between the 4th to 5th decade of life. But be aware that we see patients with PPGL all across the age spectrum. And all of us in healthcare during studies have heard of the classic triad of symptoms, which includes headache, which is present in a highly amount of patients that are symptomatic, sweating and tachycardia, that classic triad. Of note, these occurs on PPGLs that are of sympathetic origin, which are the ones that are able to produce an excess of catecholamines. But there are some paragangliomas that are of parasympathetic origin, who are do not produce excess of catecholamines, and hence could be asymptomatic. And in reality, these patients can actually have a spectrum of symptoms that can range from weight loss, insulin resistance, motility syndromes, and in terms of bowel movements, constipation, weakness, panic attack symptoms. And because of the effect of the catecholamines on the alpha receptors and the beta receptors in the cardiovascular system, we can see anything from strokes, MIs, arrhythmias. So that's something very important to keep in mind in terms of the medical history. Many times these patients come to dedicated adrenal centers after somebody has suspected the diagnosis and has obtained plasma metanephrines or 24-hour urine collections for metanephrines, followed by a dedicated adrenal imaging or dedicated adrenal MRIs. And it's very important to also remember to include the genetics evaluation. There's no perfect test in medicine. And of course, although plasma metanephrines are highly sensitive, they are still subject to the effects of anything from mild hypertension to also medications that can be commonly used for treatment of mood disorders, as well as controlled substances like cocaine and stimulants can raise elevations in metanephrines. Typically, we would consider diagnostic of pheochromocytoma and definitely a threefold elevation. So anybody that has 2 to 3 times elevated plasma metanephrines, we have to consider that as diagnosis. And especially in cases that we're suspecting that there could be metastatic or multifocal disease, patients that have pheochromocytomas that are more than 5 centimeters or paragangliomas that are more than 4 centimeters should definitely have staging imaging to include the chest. More and more, we have seen that the PET dotatate, given the presence of somatostatin receptors in these neuroendocrine tumors, has been a sensitive test with more than 90%, and it's used in the cases that there's a very high suspicion for metastatic disease. And of course, MIBG scans, which can be providing information whether patients are candidates for therapeutic therapy with etc. or high specific activity MIBG. In terms of the surgical approach recommendations, which is always the first question whenever we have a diagnosis of pheochromocytoma, is resectability. There's a clear consensus between the American endocrine surgeons, NANETS, and Endocrine Society that patients benefit to have appropriate alpha blockade prior surgical resection to provide better control of during intraoperative procedures. And this has allowed to have a significant decrease in the mortality of patients during any procedures. In patients that have or are at risk of bilateral pheochromocytomas, it's important to consider cortical sparing adrenalectomy by skilled surgeons to try to minimize the resulting adrenal insufficiency and steroid dependence. And there's also the consideration in cases of metastatic disease of the potential to improve the overall survival in these patients if there is a resection or debulking of the primary tumor. The appropriate preoperative management, as well as management of prior any procedures or even systemic therapy, includes alpha blockade therapy. I typically prefer to use doxazosine or prazosin, terrazosine as they're widely available and tend to be less financially toxic than phenoxybenzamine, but all depends on where you are practicing. Very important to ensure that the patient has alpha blocker on board prior considering beta blocker therapy. And usually we add the beta blocker if there is any reactive tachycardia. Patients that are undergoing preparation for surgical procedure should have a high salt diet, as the catecholamines can cause intravascular volume depletion. We follow these patients by keeping in communication every 3 to 4 days and obtaining orthostatic vital signs from their home log. And the idea is to have blood pressures definitely less than 130/80, ideally with systolic in the 120s, and definitely orthostatic vitals with systolic more than 90 with a target heart rate, ideally in the 70s. 80s, and to have a skilled anesthesia that follow intraoperative operative protocols, have nicardipine at hand, and definitely monitor for post-op hypotension and hypoglycemia. As we mentioned in the beginning, given the high association of germline alterations, it's very important to think about the possibility of a genetic syndrome and have all patients with paraganglioma, whether a single paraganglioma, any size, up to pheochromocytomas that are metastatic, undergo genetic testing. As we have seen, definitely in the multiple endocrine neoplasia type 2, at least around 50% risk of pheochromocytoma tends to be higher in the red 918 and red 634 alterations. There have been also some case reports that adrenal adenomas could be pheochromocytomas in multiple endocrine syndromes type 1. Definitely something to be on the lookout for our neurofibromatosis patients and our patients with bone Hippo lindau, and also ensuring that we're doing the appropriate screenings for any additional tumors. Now, we should also not forget about the cluster of 1 hypoxic tumors, which are basically derived from alterations in the STH system. And these paraganglioma type syndromes, depending on which alteration varies the location, but very important to highlight SDHP as it has the highest risk of developing metastatic disease between 40 to 60%. And the genetic alterations can also have an influence on what is the biochemical profile and the presentation in terms of patients. We also have already established protocols that have been published by great colleagues in the field in how to monitor asymptomatic carriers at both the pediatric and adult stage by ensuring that they have an initial thorough screening followed by yearly blood pressure measurements and biochemical evaluation with plasma and urine metanephrines, and every certain amount of years using MRIs to minimize the impact of radiation in the surveillance. It is very important to highlight that as an orphan disease, patients do benefit of having that multidisciplinary care because in terms of the overall survival of metastatic pheochromocytoma paraganglioma, there's a whole spectrum at 5 years between 50 to 70% overall survival, and the timing of systemic therapy is something that should be considered in a multidisciplinary discussion, and this actually becomes even highly magnified in centers that take care of patients that are of lower socioeconomic status or underrepresented minorities in medicine to ensure that we minimize health disparities. The approach for patients that suffer from unresectable or metastatic disease, definitely for those should include if they have an excess of catecholamines, to have the appropriate alpha blockade prior any localized therapy, whether ablations, they still should be alpha block, and that alpha blockade should remain 3 to 4 days afterwards. And then consideration of evaluation definitely for MIBG status, as there is an FDG, there is an MIBG high specific activity approved therapy, I should say, etc. And for those cases that are MIBG negative, given the high avidity to somatostatin receptors, there's also the study of Lutathera in clinical trials. It's very important that these patients, whether they have primary resection or if they have a locally unresectable disease or distant metastasis, even if the behavior appears to be something indolent, they need to be watched closely because there is a cohort of patients that can have rapid progression. So most societies do agree that in those cases, they should be monitoring every 3 to 6 months in terms of systemic therapy for patients that are rapidly progressing, and especially those that are MIBG negative, definitely consideration for chemotherapy. Cyclophosphamide, vincristine, and the carbazine combination has been around for years and has provided a partial response of approximately 40%. There's studies evaluating temozolomide as a more gentler side effect profile. Never forgetting from an endocrinology standpoint, I cannot, not highlight the importance of ensuring that those that have bone metastasis, which tends to be the second most common place of metastasis, that they have anti-resorted therapy, given it has been shown that a high percentage of patients could have a skeletal event or fracture within the year of diagnosis of bone mets. Remembering the role of ablative therapies, either for palliative reasons or to defer for some time the initiation of systemic therapy. Definitely the consideration of radiopharmaceutical therapies. And there's also been exploration of TKIs like cabozantinib, which in some preclinical data has also shown potential partial preliminary responses, partial responses up to 40%. And then more recently, the hypoxia inducible factors like belzutifan therapy is also under investigation, and we hope that many options to come. Briefly going through the study that led to the high specific MIBG activity approval for those cases that have high MIBG activity. It was a study with 74 patients with a median age of 54 years, but it included patients all across the age spectrum, some that majority had been treated before with surgery, and some had received additional lines of therapy. A metastatic pattern follows the usual expected pattern that we see reported initially in lymph nodes, followed by bones, then lungs and liver. And the primary endpoint of this study was actually very interesting. It was looking at reduction of all antihypertensive medications by more than 50% for more or equal to 6 months, and 25% of were able to reach that endpoint with at least one therapeutic dose. Interestingly, there's also objective responses by RECIST criteria in up to 23% partial responses and nearly 70% of stable disease. It does come like many radiopharmaceutical therapies at a price towards the bone marrow. So definitely something to consider if there's a case that's MIBG avid and the rate of progression allows to consider MIBG first rather than needing to go to chemo. It's something that I always balance to try to minimize the impacts on chemotherapy on the bone marrow. And again, we're all looking forward to see the potential data on Lutathera and many more options to come in terms of additional potential targets in these neuroendocrine tumors. I certainly could not end the presentation without thanking NANETS for the opportunity to raise more awareness to our colleagues in the field and all the attendees of this webinar, as we all hope that one day we even have additional more therapies and potentially a cure for all patients with Pheo para, regardless of their MIBG avidity status. So I thank you all for the opportunity. I'm thankful for all the colleagues at the different institutions that I train and for the patients that trust their lives to us every day.
Dr. Agosto Salgado, what an incredible presentation. Thank you for all of your talks. As a reminder, if you want to claim credits for this webinar, please visit the website list. Now let's open the floor for questions, and please place your questions for our presenters in the Q&A box. And with that, there's quite a few questions. So the first question that I'm going to ask is for Dr. Pegna. Regarding the slide showing positivity on the FDG PET scan and higher grade neuroendocrine tumors or atypical tumors, what to make of typical low-grade neuroendocrine tumors that are highly avid on FDG PET scan? This is referring to the lung carcinoid with no somatostatin receptor positivity.
Sorry, was that a question for me or for Dr. Jara?
For you, Dr. Pegna.
Okay. Sorry, I think that slide may have been Dr. Jara, but so in terms of FDG PET positivity in higher grade or atypical tumors. So yeah, that's a really good question, and it's something that we encounter not infrequently. I think increasingly we're finding that the role of bimodality PET testing is really critically important in terms of a prognostic test for patients as well. We know that the pathology on neuroendocrine tumors there's a risk of sampling error. There's the possibility of tumor heterogeneity as well. So what is helpful is actually getting oftentimes both tests, because we know that FDG positive disease tends to behave more aggressively. Now, of course, there's an important role for this in a predictive nature as well, and that many of our treatments that we utilize their utility is a little bit dictated by the positivity on dotatate PET imaging. So I hope that answers that question here.
Okay. That's great. The next question that will be for Dr. Jara. The question is that when you have a patient with pancreas neuroendocrine tumors, do you test for all hormones or just based on symptoms?
And in general, that's really a bimodal response. I will say that actually you can have two different ways of approaching. In general, a lot of people will actually do based on symptoms, right? If you have the symptoms, as the majority of the tumors are really non-functional, so you will base your symptoms to test. In majority of cases, I'm actually testing all the hormones in the patients. So you can do in both ways, and there is no right or wrong in that answer. But in general, if you want to approach it, like if you have a lot of experience, normally you'll probably test based on symptoms.
Okay, that's good. Great. The next question will be for Dr. Agosto Salgado, and the question is if norepinephrines are mildly to moderately elevated, would you repeat, and what would be the cause of this if this were not to be a Pheo?
Yeah, so tumors that are functional, we tend to see an elevation that's proportional to the tumor size. So, so that's definitely something to take into account. In terms of very mild to moderate elevations, you always in that setting, evaluate the patient if there is presence of hypertension, an extensive review with the medications. And there are circumstances where if I feel that there could be a medication culprit and it's something like an allergy medication or a supplement that we're not very sure but we can potentially hold for a brief period of time and repeat. We do that. Obviously, if it's something sometimes is psychiatric medications that the risk benefit of stopping it's limited, then we individualize that case scenario and determine obviously and about if there is an adrenal adenoma. That's where also weighing in on that imaging characteristics on an MRI and the Hounsfield units on the CT becomes very valuable.
Okay. And in those patients where you cannot stop the antipsychotics just for the risk of relapse, what would you do in those situations?
So there's always also the possibility of, even though plasma metanephrines are highly sensitive, you can also obtain a 24-hour urine collection, kind of compare both of them. And if there is a high index of clinical suspicion, then I would, obtain the imaging.
Okay, great, thank you. The next question is for Dr. Pegna. Dr. Pegna, you mentioned earlier about the data from Dr. Pomier that intraoperative octreotide is no longer given because regardless of the intraoperative octreotide, the patient still develop carcinoid crisis. And the question is, and what would you do if the patient develop carcinoid crisis intraoperative?
Yeah, so intraoperatively, so I think this is where so much of neuroendocrine tumor care is multidisciplinary. And this is the classic case of it, where it's your surgeon, it's your anesthesiologist. Supportive care is critical, utilization of pressors, having the availability for ICU level care, because we know that even if carcinoid crisis starts off as it's a mild vital sign changes, it can quickly devolve into something more serious. So I think early detection and having the benefit of an experienced team to be aware of the possible manifestations, but also the supportive management being quickly available for these patients.
Okay, great. And on that sentence, I just wanted to ask a question from Mrs. Gianni, that's from NANETS. And one of the questions is like, you answered the question about how you cancel patients who are concerned about crisis with surgery and procedures, but what happened with those non-neuroendocrine tumors related surgeries or procedures, since that's a common question that she gets in the patient advocacy.
Yeah, so generally I counsel patients in that it's really where we see tumor manipulation and the use of general anesthesia are the highest risk for triggering carcinoid crisis. But really, carcinoid crisis, though it's rare, even sort of more minor procedures or unrelated surgeries can also trigger it as well. So it's just everything being done with a high index of suspicion for patients, and when a procedure is done is the best thing that can be recommended. I don't think we are routinely using, like I mentioned, preoperative octreotide, but it's not like I stop patients long-acting octreotide either beforehand. So I think, again, early recognition is key here, and just awareness.
Great. Thank you so much, Dr. Pegna. Dr. Jara, another question that I have here is, when would you recommend liver-directed therapy in a patient with metastatic, functional metastatic pancreatic neuroendocrine tumor?
Yes, and in that situation is of liver predominant disease or liver confined disease that is not amenable for surgery. That will be the main indication.
Okay, great. Thank you. The next question I will ask to Dr. Salgado, and the question is that in patients with metastatic pheochromocytomas and paragangliomas, where insurance may approve only one functional imaging studies, what would you recommend, MIBG or 168 gallium 64 copper dot scan?
Yes, so definitely, it's definitely one of the challenges that we encounter, because of course we would love to have both. So in reality, so I'm a very strong advocate to evaluate patients for MIBG therapy. But if I'm concerned that I want to ensure that I know all the potential disease sites, I would consider a dotatate to ensure that we have that high sensitivity, given the concern that some of the patients with metastatic disease can actually also have a mixed population of tumors that might be avid and not avid to MIBG. So I think, first of all, we need to know what we're dealing with. So if I were in need of a strong picking one, then I would start with that one. Okay. And then, yeah, and then based on that, many times then if we have progression based on the dotatate, then we can justify, given the FDA approved therapy, the need to have an MIBG for candidacy for that therapy.
Okay. Thank you so much. The next question is for Dr. Pegna. And the question is, in your presentation, you mentioned about the value of BNP in patients with carcinoma heart disease. Would you recommend routinely measure the BNP, and what are the levels to consider changing in management?
Yeah, that's a great question. And I do. And patients who I have confirmed carcinoid syndrome, I make obtaining a pro-BNP a routine part of the lab. So every 3 months, every 4 months or so, anytime I obtain labs, I get a pro-BNP. Now, this can, of course, be complicated because people can have heart disease outside of carcinoid syndrome, and that requires coordination. Once again, as is such a common theme in neuroendocrine tumors, but with other disciplines, cardiology. That said, for me, especially if I have a patient who has a normal BNP, anytime I see the change go from normal to above the upper limit of normal, that my index of suspicion is high enough that I want to have an echocardiogram to evaluate that change.
Yeah, that's good. The next question is for Dr. Jara. And the question is, I have a patient that developed hypothyroidism on lanreotide. Do you recommend checking thyroid function tests routinely?
The chances, normally we know somatostatin analogs decrease TSH secretion, actually. So in the pituitary specifically, it can actually act on the deogenesis. Now, how that manifests clinically is different. It's very rare. Usually less than 1% of the patients will develop clinical significant hypothyroidism. So really the chances of having a clinically significant hypothyroidism are low. So necessarily checking that often is not necessary.
Okay, thank you. The next question is for Dr. Salgado. I hope it's okay to answer a couple of questions. We are all 7 p.m., but it will be important, I think, to answer these 2 questions. So the first question is, in a patient with metastatic pheochromocytoma and paraganglioma that has been exposed to chemotherapy, alkylating agents with multiple bone metastases, what would be your recommendations in terms of radioligand therapy, and what would you look for that recommendation?
Definitely the status of the bone marrow and the white counts. So patients that have been exposed to chemotherapy and that have a lot of bone mets and radiation, we have to be careful of exposing to potential agents that would further suppress the bone marrow function, because both in the MIBG treated patients and patients that have been treated with Lutathera, we have data from the NETs that they could develop a myelodysplastic syndrome or complications from bone marrow failure.
My apologies. If that's one of the concern, what other options will we have for a patient where we're concerned about bone marrow failure?
Well, definitely, in that scenario, obviously consulting with a hematologist and just, having, weighting the risk versus benefits, seeing what are the other lines of therapy. Is there any way that we can support the bone marrow should an event, should it, decline further? And obviously, as a strong advocate also for trials, exploring what are the newer options out there and not necessarily committing that radioligand therapies are the only options to go.
Thank you. Thank you so much for that answer. And then the last question, if I may allow to ask, is about, that would be for Dr. Pegna. My understanding is that the sensitivity of plasma HIA and urine HIA is sensitivity is the same. Knowing the inconvenience of a 24-hour urine HIA, would you recommend obtaining a plasma? And if so, where would that be?
Yeah, I prefer using urine 5-HIAA 24-hour urine collections. I know it can be an inconvenience to lug around a jug for 24 hours. That said, it is the most, we have the most robust data utilizing urine 5-HIAA. It's not to say that in the future I don't see a more specific role for plasma 5-HIAA developing, but right now I limit my use to if there's specific circumstances, patients where it's just really not feasible to collect a 24-hour collection, with my preference still being that at this time.
That's great. Well, I know there is a few questions that we couldn't answer, but that said, I really appreciate all the speakers for wonderful presentations today. And with this, finished our webinar, and look forward to seeing future webinars with NANETS. Thank you.
Thank you.